Hello everyone, this is me Bharat and welcome to this YouTube channel Deep, the world of medical videos. This is something I have been trying from last 1.5 years and finally it has been made possible. Today we have with us a wonderful teacher, Dr. Bhupendra Shah from the Department of Internal Medicine, B.P.Koirala Institute of Health Sciences. Recently he has won the Best Teacher Award in Clinical Sciences in the year 2018 and I am very much grateful to him for sharing his knowledge and experience. Today's topic is neurological weakness and we will be uploading this video in the subsequent part from the basic to the clinical applied part. So learn from the video and make your concepts clear. Thank you.
Okay, good morning. So basically what we are going to do is that we are going to make a video on how to approach a patient with any neurological symptoms or the signs. These are the videos which will be useful for the MBBS student and those students who are doing their MD internal medicines. So in this series, first of all, we are going to make a video on how we are supposed to approach a case of neurological weakness. So here, while approaching any patient with neurological weakness, first of all we should have some knowledge about the basic neuroanatomy. So in the basic neuroanatomy, I think if people know what is this, okay. Oh, this is the funny diagram. Here we can see a cell body and this is a axons. The axons are lined by the myelin sheath. Okay, so what is the function of the cell body? The basic function of cell body is to generate the impulses and process the impulses. Once the impulses are generated and processed, these impulses are transmitted through the axons. So there are millions and millions of the neurons in our body. So when there is a collection of this cell body, now if there is a collection of the cell body here like this, okay. So when there is a collection of this cell body, it forms the gray matter. And when there is a collection of these axons, it forms the white matter. Okay. Then what happens in our cerebral cortex? In the cerebral cortex, what we see is that in the outside layer, what you can see is that there is a collection of the cell body here, and in the inside there is a collection of the axons. So this outside layer is a gray matter and the inside layer is a white matter. So even within this white matter there is a collection of some cell bodies. These cell body are called the basal nuclei or basal ganglia. Somewhere there can be the collection of the cell body which is also called the thalamus. So the basic neuroanatomy is that when there is a collection of the cell body, it forms the gray matter and that is responsible for the impulse generation, impulse processing, and when there is a collection of the axons, it forms the white matter, and the basic functions of the axons is to transmit those impulses which are generated by the cell body. And within these axons, there are some collections of the cell body. These are called the basal ganglia or the thalamus. That what we need to understand regarding the basic neuroanatomy of the brain. Okay. Then after this, what we have to do is that let us make a coronal diagram of the cerebral cortex Okay, this is just a rough diagram of the cerebral cortex. In this coronal diagram, so what is the corticospinal tract? So the corticospinal tract is a tract which is responsible for the motor functions. So the origin of corticospinal tract, as the name suggests, it arises from the cortex and ends at the level of the spinal cord. So where are the cortex? So at the cortex there is a central sulcus. There is a central sulcus. There is a central sulcus, and in front of that central sulcus there is a primary motor area, and from that primary motor area the corticospinal tract arises, especially from the layer 5 of the primary motor area, where there is a giant cell called the giant cell of the Bech, or another name is the pyramidal cells. That's why corticospinal tract is also called the pyramidal tract, and that get originated from the primary motor area just in front of the central sulcus from the frontal lobe. Some of the part of the corticospinal tract also arises from the supplementary motor area, premotor area that lies in the frontal lobe, and some of the fibers also arises from the post-central gyrus. So this is how the corticospinal tract arises. Now let us see the diagram. Suppose these are the cell body that makes the corticospinal tract. Okay, and it likes just radiations. This is what we call the corona radiata. These all corona radiata will pass through a structure called internal capsule. So basically from the posterior limb of the internal capsule, all the fibers of the corticospinal tract passes, and the fibers of the corticobulbar tract passes through the genu of the internal capsule. So basically internal capsule is the collection of the axons, where the axons are densely located in the internal capsule. From the level of the internal capsule, it has to pass through the brainstem, brainstem, and as we know, the brainstem is made up by the midbrain, pons, and the medulla oblongata. So the fiber corticospinal tract will come, and about 80 to 90% of the corticospinal tract crosses to the opposite sides. Okay, and around 10 to 20% of the fibers runs ipsilaterally, and this is what happens at the lower level of the medulla oblongata. At the level of the spinal cord, so at the level of the spinal cord, what happens? You can see this structure. Probably you people know what is this structure. This is the central canal. Now what happens is that at the level of the spinal cord, this tract, corticospinal tract, passes from the outer layer. Now can you guess what we call this outer layer of the spinal cord? It is grey matter or white matter? Yes, because there is from the outer layer of the spinal cord, the corticospinal tract are being passed, and that's why it is called white matter, because it is just axons lined by the myelin sheath. But at the level of the spinal cord, what happens? This tract will give the another information to the grey matter, especially at the anterior horn of the spinal cord. So there will be the communication at the level of the anterior horn of the spinal cord, here, near about here. From there, another neuron will come out. like this way, and this neuron will form the neuromuscular junctions, and at the level of the muscles, here is the neuromuscular junctions, it will release the acetylcholine, and that contracts the muscle. So this is what is the basic neuroanatomy to understand the patient with the neurological motor weakness. So I'll repeat again. So corticospinal tract arises primarily from the primary motor area that lies in the frontal lobe, just in front of the central sulcus. This corticospinal tract will give the corona radiata. Those fibers will be densely packed in the posterior limb of the internal capsule. Then the brainstem, midbrain, bones, and the medulla oblongata. At the level of medulla oblongata, there was the crossing. Mean that the fiber coming from the right side will cross to the left side. At the level of medulla oblongata, near about 80 to 90% of the fibers, and from that level, at the level of spinal cord, it will runs through the outer part of the spinal cord, making the white matter, and from there another neuron will go to the anterior horn cells of the spinal cord and will supply the muscles of the different parts of the body, that may be the upper limb. So the neurons of the upper limb will come from the cervical region of the spinal cord. Neurons of the lower limb will arise from the probably the lumbar region of the spinal cord. Neurons for the abdominal and thoracic region will come from the thoracic region of the spinal cord, and these neurons will make a neuromuscular junction just near to the muscles, and ultimately muscle will get contract. So this is a basic neuroanatomy. Now so what happens in a clinic? Your patient may come with the weakness in the right upper limb, maybe in the left upper limb, maybe the patient may have the weakness of all the limbs. So how we are supposed to approach? So the problem may be at the level of the muscles. Okay, there are so many disease of the muscles. Problem may be at the level of the neuromuscular junction. Yes. Problem may be at the level of the nerve. Problem may be at the level of the anterior horn cell. Problem may be at the level of the spinal cord, maybe at the level of the brainstem. Yeah, then similarly at the level of the internal capsule, maybe at the level of corona radiata, and maybe at the level of the cortex. So how we have to locate where is the problem? And this is what the most fascinating approach to the patient with the neurological weakness. Okay, now for that, so after this basic neuroanatomy, so we will discuss regarding some terminologies that will be useful while approaching a patient with the motor weakness. So one terminology is that what is weakness? Yeah. Then another terminology is what is fatiguibility. Okay. So can you guess what is the difference between the weakness and the fatiguibility? Okay. I can lift this marker. This is my normal power. But if I could not lift this marker, I could not lift it, then that is a weakness. So weakness means that reduction in the muscle power, that is appropriate regarding the age, regarding the gender of the patient. So if I could not lift my hand, if I could not walk, then mean that I have a weakness in the hand, or I have a weakness in my leg. So weakness means the reduction in the power of the muscles. But then what is fatiguibility? Fatiguibility means inability to sustain the action. Like, so if I am lifting this marker, then I can lift. I am lifting it, mean that I have a normal power. But if I could not sustain it, so like that, then that is called a fatiguibility. We cannot sustain the muscle contractions if we have a fatiguibility. Then, so after knowing the difference between the weakness and the fatiguibility, you should be very, very clear from the beginning what I am dealing with. Am I dealing with the weakness or am I dealing with the fatiguibility? So there are another term like bradykinesia. What is bradykinesia? So bradykinesia, as a word suggests, brady, slow. So if I have to lift it, I can lift it, I can sustain it, but I am taking more time, then that is called bradykinesia. That is the slowness in the movement that you will classically seen in a patient with Parkinson's disease. That is a bradykinesia. That is just a slowness in the action. That is a bradykinesia. And another term is apraxia that you need to understand. So what is apraxia? Sometimes what happens? So if you ask your patient to lift a marker, though there is no any weakness, your patient has a normal muscle power, your patient do not have the bradykinesia, your patient do not have the fatiguibility, but your patient will be confused what to do or what not to do. So if there is any problem in the idea generation, and if somebody has the difficulty to perform the activities which is usual for that individual, despite having the normal motor sensory functions, then that is called apraxia. And the apraxia classically you will get in a disease of the frontal lobe. Okay, so weakness is a reduction in the muscle power, fatiguibility is the inability to sustain the action, bradykinesia is the slowness of the movement, and apraxia is the difficulty or impairment in the idea generation to perform any activities despite the normal motor and the sensory function. Okay, now you also understand regarding the terminologies. Then regarding the anatomical involvement of the weakness. Suppose if somebody has the weakness only in the one limb, suppose if I have a weakness in my right hand, then that is what we call the monoparesis. If I have a weakness in the half part of my body, if I have a weakness in the right hand as well as the right leg, then that is called the hemiparesis. If I have a weakness in my both lower limb, that is called the paraparesis. And if I have a weakness in all my limbs, both upper limbs as well as the lower limbs, that is what we call the quadriparesis. So monoparesis means weakness in the single hand, single limb. Paraparesis means the weakness in the bilateral lower limbs. Quadriparesis means the weakness in all the four limbs. Okay. And the hemiparesis means the weakness in the ipsilateral part of the body, that is called the hemiparesis. So your patient can present with the history of monoparesis, your patient can present with the history of paraparesis, your patient can present with the history of quadriparesis, or your patient can present with the history of hemiparesis. This is how your patient is going to present in the emergency room or maybe in the outpatient department. Okay. Then after knowing the basic neuroanatomy and the terminologies of the motor functions or motor impairment, then we'll try to locate where is the problem. So for that, what you need to understand is that, as we have already discussed, the corticospinal tract arises from the cortex, then the coronary rota, then the internal capsule probably, then at the level of the medulla oblongata where there will be the crushing to the opposite side, and at the level of the spinal cord, at the level of the spinal cord, from here it will go to the anterior horn cells, then ultimately it will form the, okay. So what we need to understand is that till this part from here, that is from the cortex to the anterior horn cell, that what we call the upper motor neuron, upper motor neuron, upper motor neuron, okay, and from the anterior horn cells to the level of the muscle, what we call is the lower motor neuron. So upper motor neuron start from the cortex and terminate to the anterior horn cell of the spinal cord, and the lower motor neuron start from the anterior horn cells to the muscle. So if there is a upper motor neuron lesion, like that may be the lesion in the cortex, that may be the stroke at the level of the cortex, that may be the brain tumor, or if the lesion is at the level of the coronary rota, internal capsule, brain stem, and up to the level of the spinal cord. The spinal cord classically you can get in a case of the compressive myelopathy, or sometimes there may be the transverse myelitis. These all lesions are called the upper motor neuron lesion. Okay. Then if there is any lesion in the anterior horn cells, then the roots, then the nerve and the neuromuscular junctions and the muscles, these lesions are called the lower motor neuron lesion. So how we are supposed to classify, and what are the peculiar characteristics of the upper motor neuron lesion and the lower motor neuron lesion? Okay. Then for that you need to understand regarding something about the local reflexes. So from the level of the spinal cord, it is just a motor component, okay. Then from the sensory part, the sensory will come from the dorsal root ganglia, then the dorsal root ganglia it will go to the posterior horn of the spinal cord, then okay. So at the level of the muscles and the spinal cord, there is a locally acting reflexes. So if there is any changes and any changes in the pressure, any changes in the tension, then that can be detected by the receptor in the muscles. That change will be transmitted by the sensory component, and at the level of the spinal cord, from the posterior horn to the anterior horn, and it will stimulate the anterior horn to make the changes according to the impulses. So this is the locally acting reflexes that is present at the level of the muscles. Now what happens? So if there is any problem at the level of the spinal cord, if there is any problem at the level of brain stem of the cortex, what is removed here? So remove is that, so what is the problem here is that the control over this locally mediated reflex will be lost if there is any lesion in the upper motor neuron lesion. That's why your muscles will show the independent actions. So it get hyper excited. So if it get excited, then the tone of the muscle will be increased. That is what we call the hypertonia. So if there is a loss of the upper motor neuron control over the locally mediated reflexes, the tone of the muscle will be increased, and the increase in a tone is a feature of the upper motor neuron lesion. So if your muscle is spastic, mean that you may have a problem in a upper motor neuron, that may be the spinal cord, or maybe brainstem, or maybe the internal capsule. Okay. So one is tone. Tone will be increase in a case of upper motor neuron. Now think about some lesion at the level of here. Now if you have a problem at the level of the nerve, then what happened? Oh, there is no action of even the locally mediated reflex. Okay, if there is no action of this locally mediated reflex, then from where your muscle is going to contract? Your muscle will get flaccid, relaxed, mean that so flabby, and that what we call the decrease in a tone that we will classically get in case of the lower motor neuron lesion. So the hypotonia is a feature of the lower motor neuron lesion. So if you have any problem in the lower motor neuron, maybe in the anterior horn, peripheral nerves of the neuromuscular junctions or the muscles, you may have the hypotonia. Okay. Then second difference between the upper motor neuron and the lower motor neuron is that, so if there is no control from the upper motor neuron, then what do you think? If you are giving the impulse by the patellar hammer, what will happen? You are giving the impulse here, the sensation will be carried by the sensory fibers. There will be no control from the upper motor neuron. So your reflex will be more. There will be the exaggeration of the reflex. Sometimes you may also see the clonus. So exaggeration of the reflex you will get when there is no upper motor neuron control, that is in the upper motor neuron lesion. So the reflex will be more in case of the upper motor neuron lesion. So when you hit or when you are trying to elicit the knee reflex, the knee reflex will show the exaggerated reflex. But if there is any lower motor neuron disease like in the peripheral nerve, there will be no problem. The sensory fiber will carry the impulse, but there is a problem in the motor fibers. So your muscle is not going to contract. So the reflex will be absent or maybe hypoactive. There will be decrease in the reflex if there is any problem in this lower motor neuron. Okay. So the decrease in the reflex is another important feature of the lower motor lesion. Okay. Then, okay, sometimes what you can see in case of lower motor, now if there is a problem in here in the lower motor neuron, okay, sometimes because of these injuries there will be some reinnervation. If there is any problem in the anterior horn cells, there will be the reinnervations. If there is any problem in the peripheral, sometimes there may be reinnervations, and because of this reinnervation there will be the sometimes small contractions of the muscles, that is what we call the fasciculations. Actually the fasciculations is the signs of the nerve damage, especially in the lower motor neuron lesion. Okay, so fasciculations classically you will get in case of the lower motor neuron lesion, and that's true in anterior horn cell disease. Classically, I think people know about the motor neuron disease where you can see the fasciculations. So if you see the fasciculations in your patient, I mean that think about the lower motor neuron lesion, anterior horn cells or the peripheral nerves like that. Okay, so the fasciculation is another thing that will differentiate the lower motor neuron lesion. The another important difference between the upper motor and the lower motor neuron is that your motor neuron not only supplies the impulse to contract the muscles, but there are some neurotrophics chemicals that will be transmitted, or that will be secreted by the motor neurons. And if there is any problems in the lower motor neuron lesion, your muscle is not going to contract, your muscle is not going to get enough nutrients, and because of that your muscle start getting atrophied, your muscle started going to be more thin. Okay, so the atrophy and the reduction or in the bulk of the muscles is a feature of the lower motor neuron. Okay, so these are the features. If you see the fasciculations, think about lower motor neuron. If you see there is a decrease in the tone, then think about the lower motor neuron. If you see decrease in the reflexes, think about the lower motor neuron. And if you see there is an atrophy of the muscle, think about the lower motor neuron lesion. Okay, but sometimes even in the upper motor neuron lesion, when there is acute insult, somebody having the stroke or somebody having the transverse myelitis, so there what happens is that there is a condition called the neuronal shock or the spinal shock. At the time the muscles of your patient may be the flaccid, the reflexes will be the hyperactive at the time of the spinal shock or the neuronal shock. So you people may be confused. So in the acute state, that neuronal shock or spinal shock will get over by 1 to 3 weeks. So in the acute state, even in the upper motor neuron lesion, you may see the hypoactive reflex, hypotonia and the flaccidity, but do not get confused with the classical difference between the upper motor and lower motor neuron lesions. Okay, so you should also know the history of the patient to say whether it is the upper motor and the lower motor neuron lesion. So till here, I think you people know how you are going to differentiate between the upper motor neuron and the lower motor neuron. Okay,